Welcome everybody to session 10, where we're going to focus on mental health and aging with a specific focus on Alzheimer's disease at the end. One of the key points that I want to discuss in today's session is to think about psychopathology in older adulthood or later adulthood as a real concern. Many of the older adults don't actually have psychological disorders, and contrary to what many people might expect, there are actually fewer rather than more older adults with diagnosed conditions. But we'll take a look at what the numbers say in this session. In Canada and the United States, we use the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, to figure out if somebody has or fits the criteria for a certain psychological disorder. And one of the key things that we look at is, has there been some kind of change from baseline, from the way that the person has been in previous times? And has there been an increase in some of these psychological symptoms? And the other piece is, have the symptoms persisted for a specific period of time? So when I go through some of the disorders, I want you to really think about the severity, the types of symptoms, but also that time that we should see some of these symptoms to start to consider whether it is actually indeed something worthy of further clinical investigation. What we see in this slide is the lifetime prevalence of DSM disorders by age. And we see a pattern that is quite overwhelming, where you look at differences between those who are 18 to 44 versus those who are 75 plus, as an example. And what we see consistently is that those who are age 18 to 44 have a greater lifetime prevalence of anxiety disorder, of any mood disorder, any substance abuse disorder, and actually any 3 or more disorders compared to those who are 75 years and older. So what this says is that, there's only about 20 to 25% of older adults who actually meet the criteria for any mental health disorder, and this includes dementia. And actually, it's only in the dementia case where we see a higher proportion of older adults having this mental health condition compared to younger adults. And so what we see is this key pattern where the lifetime prevalence rates of any of the DSM disorders are actually lower as we get older compared to as when we are younger. There is one caution, however. Many older adults may underreport their symptoms, and the actual prevalence figures may not represent accurately the extent of the psychological problems in this age group. So this is something to be aware of. The key point in this slide is that older adults with chronic illnesses have more anxiety or mood disorders. So I want you to pay attention to the third column, which is on your right-hand side. And so this is a table of disorders, lifetime disorders, for all those people who are 65 plus. And we look at what are some of the factors that increase the risk of having an anxiety or a mood disorder. And what we look at below is that we see that there is an increased risk of an anxiety and mood disorder when older adults have 3 or more chronic health conditions. And what that really speaks to is this issue of comorbidity. And what we mean by that is, as we get older, we don't just have one disease. We don't just have anxiety or a mood disorder. When we have either an anxiety or a mood disorder, we're also more likely to have 3 or more other chronic health conditions. So let's take depression as an example. Many of the physical symptoms of depression are things like fatigue, sleep difficulties, appetite changes, and they could be related to other chronic illnesses. So sometimes it's actually hard to disentangle, this is really a physical health problem, or is it some mental health problem? They're very much interlinked. Another key point is that there is a lot of variability among older adults who have mental health disorders. Older adults could have a diagnosis in early life, or they could have their first mental health episode in late life, or some combination of the two, where they could have something in between. Now, another key point is that it's important to look at the social context. What is happening in the life of the older adult when assessing anybody for a mental health condition, something like depression or any of the other disorders? So let's take the example of an older adult who loses interests in activities because her options are limited. Perhaps that's due to living in a nursing home. So we have to really think about what are some of the unique challenges that older adults face. So some of the unique challenges of coping with mental health problems in later life include loss of social support from family and friends, loss of income due to perhaps inability to keep working. We talked about that in our last class on work and retirement. We should also think about, lifetime exposure to stigma that's connected with, the life course perspective on aging. We should also consider negative side effects of early drug use to treat conditions. This is very specific to people that are diagnosed early in life and are living with a mental health concern as they get older. And the final issue that's unique is institutionalization in large mental health hospitals. So these are all unique challenges of coping with mental health problems in late life. Now we move on to major depressive disorder. We're going to go through some of the major mental health concerns and some of the major disorders, and I want you to really think about the symptomology and also the impact of how long that symptomology is lasting, because that's going to be a key feature that distinguishes one disorder from another. So, major depressive disorder is the experience of having, a depressed mood or a loss of interest or pleasure in daily activities, and it's typically will last for more than 2 weeks. So you have to experience some of these symptoms daily, or close to daily for over 2 weeks. And the mood has to represent a change from the person's baseline. So that's a really key feature. And that experiencing this major depressive disorder should have an impact on your social situation, your social functioning, your occupational functioning, or possibly your educational functioning. And the following specific symptoms, you have to have at least 5 of these symptoms, and you have to experience them for nearly daily. So the first one is that depressive mood or feeling irritable. And either you feel that, it's a subjective report, you feel sad or empty, or it's an observation that's actually made by other people, that they'll say, oh, he or she appears tearful. The second symptom is a decreased interest or pleasure in most activities, and you experience that most of every day. The third symptom is a change in sleep. Either you can't sleep at all, or you or you want to sleep all the time. There's got to be a change. That's the key part. There's got to be a change in activity. Either you feel very fatigued, a loss of energy, or the opposite. There's this increased agitation. There's guilt and a feeling of worthlessness, and it has to be excessive. There should be a lack of concentration, diminished ability to think or concentrate, or you feel really indecisive. And lastly, there are these thoughts of death or suicide, or even having a plan for suicide. And what we see here is that there's the lifetime prevalence is 16.6%. We see that there are higher rates in those who are 59 years and younger, and the highest rates are actually for our younger adults, so those who are 18 to 25. Now, the one caveat here is that we will see that many older adults can experience these depressive symptoms. They may not have the disorder, but they may experience the symptoms. Now, older adults may not be correctly diagnosed for a major depressive disorder. And I really want you to think about why this might be the case. So, one reason is that healthcare professionals may not be trained in the diagnosis of older adults. They may actually even have age stereotypes and think that older adults, that's normal to feel depressed. Well, it's not a normal aspect of aging. Older adults may also not accurately report their symptoms. Doctors, physicians may spend too little time with them, so to really delve deep and discuss, what's actually happening in their lives. Reimbursement rates are lower for, assessing psychological concerns compared to more physical medical concerns. The attitudes toward depression in older adults by professionals may also be an issue that prevents older adults from really talking about their depressive symptomology. Medical and psychological symptoms may actually co-occur. And this is what makes it very difficult to distinguish. Is it a medical condition or is it actually a depressive condition? We'll talk a little bit more about that when we get into dementia versus depression towards the end. Now, the key thing here is that healthcare workers should look for possible contributing psychological or psychosocial factors. We really have to think more holistically, think about the biological, social, psychological symptoms or issues that may contribute to someone feeling sad or depressed. Now, there are many risk factors for depression. They include functional limitations, so there may be difficulty with mobility, for example. There may be sensory impairments, difficulty either with vision or touch or hearing, that may worsen the experience of depression. There may be problems with self-care. They may not be able to take care of themselves and, maybe bathe themselves or feed themselves, and that can be a contributor to depression. They may be dealing with pain, physical pain. These risk factors are not mutually exclusive, right? They're highly linked. They may be in institutional settings that limit their opportunities for social engagement. They may be dealing with changes in cognition or personality. So there may be also some other cognitive issues like dementia that may also be masking or contributing to experiences of depression. They may have experienced a loss of a loved one or a family member, so they may be grieving. They may not be connected socially, maybe experiencing some loneliness. really it's important to look at some of the stressful life events that older adults may have experienced in the recent past, because that could certainly be a risk factor for depression. And really look for, are they avoiding, because that's sometimes when we try to cope with our feelings of sadness by avoiding, so that may be a concern, something to look for. And any other medical disorder. And in the next slide, we see a whole slew of medical conditions that pose as significant risk factors for depressive disorders. Now, suicide is an important concern as we get older. It's not a diagnosis in the DSM-5, but it's certainly a major risk factor. And it's something to really explore a little deeper, find out what is happening in the life of an older adult that may increase the risk of suicide. Ask about marital breakdown, finances, changes in finances, physical changes related with aging, any major losses or psychological, or the lack of social support. These are all things that may increase the risk of suicide or even feelings related to that, to suicide. You can see that many of the risk factors are psychosocial, which is why, as you'll see later, an assessment must be multi-dimensional. What I mean by that, it must include the biological aspect, the psychological aspects, and the social aspects that can increase the risk of suicidal feelings among older adults. Next, we'll look at some of the facts related to suicide. It is the 9th leading cause of death in Canada. Far more males are more likely to commit suicide than women, and we see actually the highest rates is actually among older white men. And we see that those who are single or widowed are more likely to commit suicide compared to their married counterparts. We see that there is this increase, right? We're in middle age, where people 45 to 49 are most likely to commit suicide, and then the suicide rates decrease between 65 and 69, and then they go up after that, after 69. And what's interesting to note is that often older adults will have like mild or moderate symptoms of depression, but they're still very at risk of experiencing suicidal feelings. I want you to pay attention to the gray box here that says that up to 76% of those who have actually committed suicide have seen a healthcare provider within months of their death. So it's really important to begin that conversation and really ask about feelings of suicide, thoughts about a plan with older adults during that clinical encounter, because that could be a prevention strategy. So in this next slide, we see that mortality rates due to suicide, and we see that the rates are really much higher for men, right here, compared to women, especially among that 85 plus group. Next, we move on to bipolar disorder. And this is where you experience, one or more manic episodes where you feel like very elated, highly energetic, can just feel like the life of the party. And then you also may or may not have a depressive episode, a coinciding depressive episode. We see that the lifetime prevalence is much lower. It's 3.9%. At least half begin before a person reaches the age of 25. So this really concerns the younger adults more than older adults. And we're only now really learning more about how the role of bipolar disorder in later life. And there may be some neurological components. And we really discussed this more in depth in the Aging Mind course. Next, we just look at anxiety disorders in general, and typically anxiety disorders, like one of the key symptoms is this feeling of dread about the future, and people will go through lengths to avoid anxiety provoking situations, and that's why we see like phobias fall under anxiety disorders, because people are afraid to actually confront the things that could cause anxiety. And this is most highly prevalent of all psychological disorders except for substance abuse. So we see that the prevalence rates are quite high at nearly 30% lifetime prevalence rates. However, the same pattern that we talked about in the beginning of the session, we see that the prevalence rates are lower in people age 60 plus. Older women, however, have higher rates than older men. Now, let's consider why the prevalence rates might be lower among older adults. So take some time to think about why that may be true. One of the theories is that older adults may be more resilient, right? They've learned how to cope with stressors, and by the time they've reached older adulthood, they have developed strong coping strategies. Another reason could be that healthcare professionals may not recognize these symptoms in older adults, and as a result, these prevalence rates are sort of underestimating the experience of anxiety among older adults. And finally, sometimes these medical symptoms coexist, and so it's difficult again to disentangle. Is it a medical symptom, or is it actually an anxiety issue? So failing to diagnose anxiety disorders can actually be associated with an increased mortality. And as I mentioned before, whenever you see that something is a risk factor for increased mortality, you must pay attention because it's an issue of life and death. So it's important to really look and really hone in on those abilities to diagnose anxiety disorders across the life course. Now, there are other anxiety disorders, like some specific ones are general anxiety disorders. This is this general fear of dread that is pervasive and impairs one's ability to function. So we see this in people who are prone to worries and feel very restless and tense. And the lifetime prevalence is pretty low, it's 5.7%, but among older adults, it's quite low at 2%. Another anxiety disorder is the obsessive compulsive disorder, and so this is where you may focus on a specific act like hand washing and do it over and over. Or another type of anxiety disorder is a phobia where there's a specific fear of death, fear of animals. So those are quite there's a range of phobias out there. Next, we look at something that is actually so more and more research and more attention to trauma and stress-related disorders. And the symptoms here are things like reminders of distressing situations, or people may avoid situations that remind them of certain events. So if there's an anniversary that's very distressing, they may avoid going to certain events that highlight some experience of major distress. So we've got two types that are related to stress. So the acute stress disorder, focus on the time here. Symptoms will be up to 1 month, whereas we have post-traumatic stress disorder. It's different, where we see symptoms that last for more than 1 month, and we sometimes see that post-traumatic stress experiences are triggered by certain things like anniversaries or reminders. We see that the lifetime prevalence is 6.8%. Something that older adults may suffer from is called late onset stress symptomology. Again, that's late onset stress symptomology. And we see that in older veterans who were exposed to stressful combat situations when they were younger. And these symptoms are very similar to PTSD, but the progression is distinct as it develops later in life. So the big difference is that loss is something that's late onset. We experience it when we're older, when we're typically above 65, compared to post-traumatic stress is something that we would experience in younger years, and it can certainly continue into older adulthood. Next, we'll look at schizophrenia and other psychotic disorders, and what connects them all is this distorted perception of reality. There is impairment in thinking, in behavior, in feelings, in affect, in motivation. So older adults or anybody experiencing any of these psychotic disorders will experience delusions, hallucinations, which can be auditory or visual. They may see things, they may hear things. They have disorganized and incoherent speech, but they could also have these negative symptoms. And by negative symptoms, it's the opposite of things like hallucinations. It's that the apathy, the not feeling anything, not wanting to engage. So that's what we call a negative symptom. A positive symptom are things like delusions, hallucinations. They're very active symptoms. Now, the lifetime prevalence rates are very low at 1%. And other health and mental health problems may also be associated with schizophrenia in older adults, though many show this ability to cope. One of the issues is that some people actually don't survive into old age, so that's part of the reason why the prevalence rates are low. They also have higher suicide rates, people with schizophrenia or any of the other psychotic disorders, than those without these issues. With treatment, though, 40% can recover. Now, substance-related disorders, we see new late statistics is that 4.4% of Canadians 15 plus meet the criteria for a substance use disorder. And again, those with early substance abuse are less likely to live till old age. So we see that the lifetime prevalence rates are 21.6%, but not a lot of people live until older adulthood. Now, older adults are at risk of abuse from overuse of prescription drugs. Alcohol dependence is one of the substance abuse that we do see greater in older adults, and we see as many as 14% of older adults who actually receive medical attention in hospitals or emergency rooms. We do see alcohol dependence in nursing homes and retirement communities, and there are several risks that are related to other health conditions. So again, like diabetes. So we see the issue of comorbidity that's relevant in this condition. So alcohol also interacts poorly with common medications. You'll learn about that in the Aging Body course. And chronic alcohol use can also lead to negative changes in the kidneys and the brain. So now we get into what are some of the the treatment issues in mental health care, well, some of the guidelines really focus a lot on attitudes and knowledge about aging. And this is part of the reason why we in our class focused so much on negative stereotypes about aging, and we focus on what we know is normal aging versus not normal or disordered aging. So it's very important to really do a self-assessment. As a future provider, think about what are your own attitudes about aging, because they can actually color the way in which treatment is provided to older adults. So I would really focus, look at these, and you see that there's a real focus on really understanding what is known about normal aging and how it's different from disordered aging, and really think about some of the negative attitudes we might have about adults. Assessment should always be tailored to older adults, and it should account for some of the normal aspects of aging. So consider, does the older adult have any hearing problems? Because sometimes the hearing problems may mimic as the psychological concern. We talked about this earlier in the course. So maybe somebody thinks they're hearing things. They may be having delusions or auditory delusions, and maybe it's because it's actually a hearing problem and not a psychological problem. So it's always good to assess for vision problems, hearing problems, changes in sensation and perception. Consider if there are any problems with mobility, with movement, because that can also color or affect the experience of psychological or mental health concerns for older adults. And finally, and very importantly, it's important to do an assessment of cognition and really think about, is this a problem in thinking, or is this a problem in affect or feeling? I'm going to use depression as an example. So depression is not a part of normal aging. Healthcare professionals have to advocate for treatment. Sometimes people think that, when you're older, it's normal. It's a false assumption, but people do think that, it's okay to feel depressed when you're older. That's not true. And it's very important that an assessment is multidimensional, that you consider the biological factors. What are some of the physical illnesses or disabilities that can be perhaps serve as risk factors for depression? Think about the psychological factors. Have there been any stresses in the person's life? Has there been a loss of a family member? And look at past history of depression. Those are important psychological factors to consider. And then lastly, think about the psychological factors. The social factors. So have there been, experience of stigma and discrimination across the life course that may be contributing to experiences of depression in later life? So some of the key points here is make sure you view the clients, older adults in this case, as experts of their own symptoms. Ask them about the meanings they attribute to the symptoms and respect their treatment preferences. Rule out medical conditions and medication when assessing older adults for depression. It's important to conduct a thorough suicide assessment when working with older adults who appear depressed, and really, be educated about the ways in which different cultures talk about depression. They won't use the word depressed. Maybe we use the words, feeling really sad or down. And so it's really important to be culturally competent also in the way we talk about depression. Next, we look at, assessment. So the assessment has to be not just multidimensional, in terms of looking at the biopsychosocial aspect, but it's also different types of measurements. So one of the assessment strategies is the clinical interview. So that's a face-to-face interview. But it's also important to do an assessment of cognition. So and that's what we mean by the mental status exam. Really get a sense of if there's a problem in cognition and kind of rule that out. So important to do an assessment, a geriatric depression assessment, to consider what are the symptoms of depression that the older adult may be experiencing, and also do a functional assessment. So ask them about their activities of daily living, the ADLs, things like bathing, feeding, toileting, and also the instrumental activities of daily living, the IADLs. So are they able to get around the house and cook for themselves and get to appointments? So they'll do a full, very comprehensive geriatric assessment to really understand what is going on in the life of the older adult that may pose as risk factors for depression. In terms of treatment, people can take antidepressants, anti-anxiety medication, or neuroleptics. Neuroleptics are typically given to people with schizophrenia, but you have to be mindful of some of the side effects. One of the side effects is tardive dyskinesia, and this is involuntary repetitive movements. So they become very rigid in their mobility. So it's important to think about some of the side effects when considering the medical treatments. Now, psychotherapy is also an important aspect in the treatment of older adults, not just medication. And the psychotherapy can be varied. It can be things like looking at the life review and really understanding earlier life experiences and how they impact the experiences of depression in later life. Or they could be focused on a behavioral change, and this can be things like increasing the amount of pleasant activities in a person's life, so increasing social engagement. Another focus could be cognitive, so learning how to manage some of the dysfunctional thoughts or feelings of depression, or it could be a combination of cognitive and behavioral where you're changing both the thoughts and the behaviors, or it could be focusing on some of the interpersonal skills and really developing some social skills that help increase that social engagement and reduce the risk of feeling depressed. Next, I want you to engage in this activity. We're going to move on to dementia. And what I want you to do is take out a sheet of paper and a pen or a pencil and pick up a mirror. I prefer a mirror over a phone camera because it just works so much better. So pick up a mirror and put it in your left hand, and put it in your right hand if you're left-handed. So that's the first thing. Take out a sheet, pick up a mirror, put it in your left hand. If you are right-handed, put it in your right hand if you are left-handed. Now hold the mirror up at your left shoulder so that you can look into it by turning your head to the left. And right shoulder if you're left-handed. So you're going to hold up that mirror. And while looking into the mirror, tilt the mirror down so that you can see the paper on your desk. So you're really focusing on the mirror and the mirror is going to be tilted down so you can see the paper on your desk. And looking only at the mirror, you're not looking at the desk, you're looking at the mirror, draw a house. Okay, so take your time and do that activity. You can press pause. And then once you're done with the house, still looking at the mirror, I want you to draw a clock, put in all the numbers, and set the hands for 10 after 11. So that is 10 minutes after 11 or 11:10. So I want you to take your time in doing that activity. Remember, you're not allowed to look at the sheet of paper. You're only allowed to look at the mirror while you draw the house and while you engage in the clock drawing exercise. Now, I want you to go into the discussion board, and I want you to share how you felt. What did it feel like to draw through the mirror image? So I want to see, around 300 posts that look at that really share your experience of drawing the house and drawing the clock. Now we'll begin and look at dementia. The exercise that you did gives you some idea of what the world might seem like to a person with dementia. So I really want you to draw on on the feelings that you experienced when doing the activity as I go through some of the descriptions of dementia. So in 2011, there was a new update, new diagnostic criteria and guidelines for dementia. And dementia is diagnosed when there are cognitive or behavioral symptoms that, just like in the psychiatric or psychological disorders, they've got to interfere with your functioning at work or usual activities. It's got to be a change from baseline, and it has to be a decline. There's some kind of progressive decline, and it can't be a delirium or other psychiatric disorder. And the way that we assess, and this is really key, is through this in-depth history taking with the older adult and with a caregiver, typically a family member, and through a whole battery, which is a listing of neuropsychological testing. I want you to focus on the cognitive and behavioral changes that come with dementia. And to be diagnosed, you need to have at least 2 of these impairments. So an impairment in the ability to acquire and remember new information. So this is why sometimes you see older adults with dementia ask the same question over and over. They replace belongings. They can have impaired reasoning and handling of complex tasks, so poor judgment. So symptoms will include things like poor understanding of safety risks, have trouble managing finances, poor decision making, inability to plan complex or sequential activities. So let's say you're baking, for example. Baking requires a very important stepwise functions, and so sometimes people have difficulty with that. There's impaired visuospatial abilities, and these symptoms include things like having difficulty recognizing faces. So sometimes older adults with dementia won't even, they'll be asking for their spouse even when their spouse is right next to them. They may also have difficulty recognizing common objects or difficulty finding objects that are right in front of them. They may have inability to orient clothing to their body. The fourth impairment is language, so there's problems both in expressive, so expressing oneself, so we see difficulties in speaking, but also in understanding what other people are trying to convey. And finally, we see changes in personality, and these are very, very distressing for family caregivers. And usually when we see these behavior changes, things like agitation, compulsive behaviors, resisting care, oftentimes these are what start the caregivers thinking about moving their family member into a long-term care facility. So there are lots of dementias. The primary dementias are due to some pathology in the brain. So Alzheimer's disease is one example, frontotemporal dementia. Those are very specific primary dementias. The secondary dementias are dementias that are they're associated with other conditions like depression, tumor, or AIDS. Now, Alzheimer's disease, we're going to focus a little bit on that. Most of the cases of dementia are, for now, diagnosed as Alzheimer's disease. One of the key features is that the onset is insidious, meaning that the symptoms develop over time. It's not sudden. In the case of delirium, it's very sudden. The symptoms will occur in 24 hours, whereas with Alzheimer's disease, the symptoms occur over months to years. And we see that it's progressive. And in aging, when we use the word progressive, it's negative. We see that there's a history of worsening in the cognition. And this results in the death of nerve cells, and the consequences is there's difficulty in memory, there's personality changes, and there's increased inability to manage activities of daily living. The diagnosis, just like we talked about with some of our psychological disorders, is there's a whole set of strategies, assessments that we take when assessing that somebody has Alzheimer's disease. First, we take a deep, in-depth history. There's a physical exam, there's a battery of neuropsych testing, and we only really know if somebody has an Alzheimer's disease after death. So there's an autopsy taken after death. Here we see how Alzheimer's disease progresses over time, and we see that the early stages there are problems with memory and maybe spatial disorientation, and over time we see that the person may develop more physical symptoms like incontinence, motor impairment, and resistiveness to care. Finally, I want to end with it's important to differentiate between dementia and other conditions like depression. Dementias are typically things that are not reversible, whereas other things can actually be treated more readily. And so let's take a look. When somebody has memory problems, in terms of depression, there is rapid onset. It's very different from dementia. So somebody who has depression will experience poor memory for recent and past events, and they'll be very, very stressed out over their memory problems. And they will provide details. They'll tell you all about their memory problems in in lots of detail. In contrast, dementia people with dementia have memory problems that are gradually developing over time. They retain their memory for past events, so so the long-term memory, they can still tap into that. But they have very poor memory for things that happened recently. And the key feature is they're not aware at all that they have memory problems. And in fact, they may actually hide details about their memory problems with other people. What I want to leave you with in preparation for the next session is, what are the implications of care for the rising number of Canadians with dementia? So we see that it's a complex disorder, it affects memory and personality, and eventually it actually affects like physical abilities, abilities to go to the bathroom and feed oneself. So who's going to care for these older adults? And is it the family? Is it the formal care system? And are we really prepared for the increasing number of older adults with dementia that we will see in the future?